Alrighty, so now we are going to have our afternoon keynote by Dr. Dan Friedman. So please welcome me in welcoming Dr. Friedman here. Please join me in welcoming, sorry. So Dr. Friedman is a pediatric epileptologist in our group and an assistant professor of neurology at UT and the director of our psychogenic non-epileptic events clinic. He received his medical degree from Texas College of Osteopathic Medicine and trained in child neurology and clinical neurophysiology at Nationwide Children's Hospital in Columbus. He joined Dell Children's in 2020, and he has particular expertise in the evaluation and management of complex epilepsy and functional neurological disorders. He's the assistant program director for our epilepsy fellowship and serves as the vice chair on the guidelines and assessment committee for the American Epilepsy Society. We're excited to hear his keynote presentation. Thank you.
Thank you. All right, thank you for that really nice introduction. So we're going to talk a lot about FND and what FND is and the kind of a subtype that I specialize in, which is psychogenic non-epileptic events or psychogenic non-epileptic seizures. I have no disclosures. So we're going to talk about the modern conceptualization of FND, and then we're going to go over some of the most common symptoms that we see and also how you can treat it. And I think the goal of this is really to educate people that anybody can diagnose this, anybody can treat this. So I'm a firm believer that it's not just a neurology thing, it's not just a psychiatry thing. I think pediatricians have a role to play, physiatrists, there's lots of different specialties that can make this diagnosis and be a part of this discussion. I'll throw out neuropsychologists too, because I happen to see Dr. Ivankovich. So neuropsychologists also have an important role to play because we sometimes do cognitive testing for some of these patients also. So why does this matter? This is a very common problem. So the prevalence of this is about 60 per 100,000, kind of in the peak teenage years of 15 to 19. And I would say the prevalence has grown over time. So when I first started this, we thought this clinic would be like a half a day once a month or something like that. And now we're a full day every week because this is something that just is never, once you build it, they will come, so to speak. And so we get lots and lots of referrals, and it seems like it's on the rise for whatever reason. There's also, I think this topic is really important to me because I had an experience in residency where I was talking to a family. They had just been discharged earlier that day, and I was the on-call resident. I was a PGY3, so I was kind of new to child neurology. And I get this call from this very angry dad saying that he just got discharged. He doesn't know what's going on with his daughter. They didn't explain anything. They just said, good news, it's not seizures, and they discharged him. So he demanded to come back to the ER that night. I met them in the ER, and I watched this teenage girl have this non-epileptic event right in front of me. As soon as I introduced myself as the neurologist, she went into the episode. And so I explained to Dad how I knew very confidently that this was the right diagnosis, and I talked about what this diagnosis means and how we can treat it. And that was the part they had not really heard before, that there was treatment available. They just heard, good news, there's nothing wrong with you, go home. And they were very, very frustrated by that. So after about 30, 45 minutes of talking to them in the ER, Dad shook my hand, they got up and left, and they felt in a much better place about this diagnosis. And so that kind of started this whole saga of me being interested in this stuff. The other thing that's interesting is in the adult population, there's an increased mortality ratio. We don't know why that is. It's probably from psychiatric comorbidities and things like that. Unfortunately, this patient population has some of the lowest quality of life ratings of any neurological population. So patients with MS, refractory epilepsy, actually have slightly lower quality of life scores than these patients. So very, very impaired quality of life for FND patients. And then we also know there's a significant cost burden to this. So when we look at not just the per patient cost to make a diagnosis, we're looking at, and this is in Australian dollars, or sorry, it's in American dollars, but from an Australian study, $19,000 per adult to make a diagnosis of PNES, or psychogenic non-epileptic seizures. If you imagine that in America, that would probably be a lot more expensive, right? Everything that we do in healthcare is going to be more expensive than what they do in Australia, probably. And then when you look at the ER costs in the US of adult and pediatric ER costs, we're looking at $163 million, which is equivalent to about refractory epilepsy. So these patients are coming to the ER often, they're utilizing resources, and oftentimes because they feel frustrated, they're not getting answers, and so they keep coming back and back and back until they finally get, hopefully, the right diagnosis and get referred to an appropriate clinic. So FND is kind of the overall term, functional neurological disorder, and then there's subtypes, of which one of the subtypes is this kind of seizure mimic of psychogenic non-epileptic events. This technically falls under a psychiatric diagnosis, which is why it's in the DSM. And so it's in the DSM-5, they made a huge change, thanks in large part to the influence of neurologists. So neurologists said, we really need to change the way that we approach this diagnosis, because many decades, or over a century really, it was kind of stuck in this Freudian school of thought that this was a trauma response and it was a conversion disorder, right? So we finally dropped the conversion disorder nomenclature and moved to this FND terminology. And so that came about in 2013. And they also changed the definition to drop any sort of stressor or psychological comorbidity necessary for the diagnosis. So all you need to make this diagnosis is having symptoms, physical symptoms that are incompatible with any other known neurological disorder, and that symptoms fluctuate. So another way to define it would be to say you have incongruency with other neurological problems, and you have internal inconsistency of the symptoms. So the symptoms wax and wane without clear explanation. There was also a recent update to DSM-5 in 2022 that switched this kind of as a further push of getting the conversion disorder terminology out of there. So it used to be conversion disorder was the main term and FND was in parentheses. Now it's the other way around. So we're kind of moving further and further away from that. Also, just on a nomenclature topic, sometimes we call these functional seizures instead of psychogenic non-epileptic events or psychogenic non-epileptic seizures. It's a lot of different names out there. You may see any of those combinations of terms. I don't police the term. I don't know we honestly don't know what the right term is. And so I just usually tell patients, these are all the three terms that you might see if you were to Google this or whatever. And so it's important to know all three terms. So here's that definition of inconsistency, incongruency. That's really what we're looking for on exam, is we want to see these changes in symptoms that wouldn't fit with any other neurological process. When we think about how does that make sense? So one of the things that often happens for these patients is they get accused of faking because of the attentional aspect of this disorder. So the more attention they focus on their symptoms, the worse those symptoms get. That's that variability and fluctuation we're talking about. And so it's not uncommon for healthcare providers to say, well, that looks fake. That person's doing that on purpose. We know that the vast majority of these patients are not doing that. Some patients, there are very rare cases, especially in pediatrics, thankfully, of malingering. I've seen a couple of adults malinger. So part of our pediatric neurology training is we do a year of adult neurology. And where I train, we had the prison contract for the state. And so I did see the occasional malingering patient. But in pediatrics, pretty rare. So most of the time, these patients aren't faking it. It's just a attentionally driven issue that we can explain by looking at the modern neuroscience of this disorder. So this is what's known as the Hallett model. So Mark Hallett was at the NIH. He studied voluntary motor control. He was the director of the voluntary motor control unit at the NIH. A lot of his research informs our knowledge of Parkinson's, Tourette syndrome, things like that. And he also was one of the kind of founding leaders of the FND world because he put all this information together and realize that there's something real here. So this idea that this is fake or all in somebody's head, there's a biological mechanism for FND. So, and it looks, the arrow's got a little bit messed up, I apologize, but the key aspect that you need to know is on the left, oh, nope, that was weird. Sorry, I thought there'd be a laser pointer there, but okay. On the, hold the button. Nope. Okay. Oh, that's very fancy. Okay. So the left-hand side is the basic motor plan that we learned in med school. So you think about making a movement, which is in your prefrontal cortex. You send that signal to the supplementary motor area, which plans the movement. And then you generate the movement in the primary motor cortex, which is the bottom left there. What that doesn't take into account is that there is a lot of feedback and feed-forward mechanisms that rely on things like interoception, which is our feeling of what's going on within our bodies, exteroception, which is our feeling of what's happening to our bodies from the outside. And then it doesn't also take into account a new neuroscience understanding of predictive coding. And so that's a theory of mine that it's been around for probably 10 or 20 years. It's, I think, largely taught in a neuropsych space, so we did not learn about it in med school. I certainly didn't. But it is kind of one of the more prevailing understandings of how our brains work. And that also relates to agency, which is the feeling of self-control over the body, and that's what we think this right temporoparietal junction, I'm gonna try this again. There we go. So this area here is the right temporal parietal junction, and that's where agency resides, we think, and that's based on some interesting studies that were done where they did awake craniotomies on patients for other reasons. They weren't doing it just for this study. But while they had the patient awake and had the craniotomy, the brain exposed, they stimulated this area of cortex, and they were able to show that you could make somebody feel as if they had moved just by stimulating this region of the brain. Yeah, you could also create the intention of movement just by stimulating. So we previously thought that most motor intention had to come from the prefrontal cortex. Now we know that you can actually create that intention of movement just by stimulating this area as well. And so that kind of got people interested in this concept of, is this area really important for integrating all these different motor features together so that we can have smooth, normal voluntary movements? And how could that relate to FND? Now we've also done studies with fMRI, and they were able to show that people with FND have decreased activation of the right temporoparietal junction, and that kind of helps confirm some evidence to support this hypothesis. So that leads us to what is predictive coding. Predictive coding is this idea that the brain is a homeostasis machine. That is its sole purpose, is to maintain order and balance. And so it has to make lots and lots of predictions all the time and assumptions about the world around us. Most of the time, those predictions and assumptions are correct, they're valid, they're kind of self-edited over time, and that's how we're able to do all the things that our body does without having to think about most of the things that our body does. The problem is, what happens if our brain makes a bad prediction? What if we pair a stimulus with an outcome? And so this can be like a stressor, right? So going to a certain class then triggers a non-epileptic event. So that's an example of how predictive coding can go wrong. That brain has now created that pathway where if A happens, B has to follow. And so what we do with treatment is we try to change that pathway and reinforce the healthier pathways that are working. This is a typical patient having a non-epileptic event. And so you can see there's some right arm shaking, kind of bilateral leg shaking. You can kind of see the left arm. You're going to see it a little more clearly when the avocado blanket gets taken away. So now you can see that the left arm is also shaking. What's interesting about this is you can see how different the left and right arm are moving. So they're actually asynchronous to each other, which is a really important feature to non-epileptic events. So if you think about an epileptic seizure, most epileptic seizures, we're seeing rhythmic electrical impulses on the EEG. That's going to drive a rhythmic physical manifestation of that. There are very rare types of epileptic seizures where you can get alternating movements like this, but for the vast majority of patients that we see alternating movements like this, we know that pretty much has to be a non-epileptic event. The video is not frozen. She has just paused her arm midair, and then she'll go back into the shaking. Interestingly, this patient, so there's a teenage girl who came in. She had been seen at multiple facilities until finally she ended up at Dell Children's, got diagnosed. She wants to, or at least at the time, she wanted to go into healthcare. And so she wanted to share this video to other healthcare workers so they could be educated on this topic. And so you could see the kind of stuttering nature of her symptoms. They start, they stop. That would also not be true of an epileptic seizure, right? We see kind of a slow buildup of an epileptic seizure, a crescendo, and then it stops. Whereas during a non-epileptic event, this will stutter and stop and start for 30 minutes, an hour, sometimes multiple hours. And so that's one of the best signs that we have that this is non-epileptic. And there's some really good data on this. So we can make a diagnosis just by looking at the clinical symptoms. We don't often even need EEG most of the time. And so long duration, fluctuating course, asynchronous movements. When I say excluding FLE, that's frontal lobe epilepsy, because frontal lobe epilepsy is that rare type of seizure that can do weird things. And that's what my job is, right? I look at lots of videos of patients that come to my clinic, and I say, okay, that movement looks like it could be a frontal lobe seizure, or that looks like a generalized tonic-clonic seizure, or for the vast majority of my patients, that movement is clearly inconsistent with the seizure. And so then I explain, based on the video, I feel very confident in this diagnosis. Sometimes that's enough for families. Sometimes families say we really want an EEG. I have no problem ordering an EEG because that's how we get the highest level of diagnostic certainty to explain that to families. And sometimes families really need that kind of closure. But sometimes an explanation is good enough, and that's why we need our clinical data here and that's why everybody having a cell phone these days is invaluable to what neurologists do. So whatever the abnormal movement is, if it's a tic, if it's a non-epileptic event, always encourage your patients to take video, and that way you can send it to the neurologist and we can make a diagnosis oftentimes just based on that. Other important signs, so side-to-side head movements, closed eyes, ictal crying, that's separate from an actual ictal cry. So there is an ictal cry during a seizure where there's a spasm of the vocal cords and diaphragm that creates kind of a harsh guttural noise. This is very separate from what I'm talking about here, which is a like sobbing crying, and that's very consistent with a non-epileptic event. One last thing on that slide. One thing that favors seizure very strongly is occurrence out of sleep. So if your patient's saying that they're having these events in the middle of the night, that'd be very, very unusual for a non-epileptic event. So that's one of the red flags I'm always looking for is, when are these events happening? Are they happening at school more than home? Are they always happening at the same time of day, the same class period, whatever? Those are nice kind of soft signs to help make the diagnosis, whereas if they tell me it's only happening in the middle of the night, that's one of the best indicators that this is probably probably epileptic seizure or parasomnia or something like that. For positive diagnostic signs, so this is if a patient's in your clinic exhibiting physical symptoms in that moment. So it's not a non-epileptic event, but it's a kind of broader FND symptom. What we look for are things like Hoover signs. So that's where you have the patient, you can have them either laying down on the exam table or sitting, and you ask them to lift the weak leg. And let me make sure I get this right, sorry. So you have them raise the weak leg. Actually, I'm sorry, you have them extend the weak leg. So if they're sitting, you have them push their leg down, and you should feel the hamstrings tightening up to extend the leg. If you don't, so let's say you have a suspicion that they have a functional disorder, you then switch to the other leg and ask them to lift that left leg, so to hip flex. And while you're doing that, you also feel behind the knee to see if they tighten the hamstring subconsciously to balance the pelvis while doing that hip extent or hip flexion. And if they're not doing that, or sorry, if they do that, that tells you that that muscle is not truly weak. It's an intentional aspect of, if they're focusing on using that muscle, they can't use it. When you indirectly activate it, they can use it. Since that was a little bit confusing, I'll also give the example of a hip abductor sign. So that's where you have them sitting. And so if you have the legs like this, and let's say the right abductor is weak, so they cannot pull their right leg in, you can have them, they cannot pull the right leg out. You have them then abduct the left leg, and they will involuntarily activate the right leg. And the reason for that is just that's how our brains work. It's just hardwired, aspect of our nature. And it's not because they're faking, it's because it is a true attentional aspect that if you ask them to move the thing that is weak to them, they have a harder time doing it. The best example I can give of that is if you were asked to walk a straight line, you could walk a straight line, no problem. If I then took that straight line and put that on the edge of a cliff, suddenly you're gonna have a much harder time doing that, right? So the more you hyper-focus on something that you're worried about, you're scared about, whatever, that all affects our agency, and that affects our ability to do those things that we would normally have no problem doing. All right, and then a couple other key ones, dragging gait. So when people say they have a weak leg, so when you see like a patient that's had a stroke or something like that, they have a hemiparetic gait, they'll swing the leg, they don't drag it behind them. So typically that is a good symptom of a FND sign as well. Tremor entrainment test is one of my favorites. So this is where a patient's having shaking of, let's say, the left hand. You have them tap out a rhythm with the other hand, and the tremor will entrain to the tapped rhythm. And so it's and it again speaks to the fact that it has something to do with our supplementary motor areas being able to maintain two different rhythms. It does not like to do that, so one tends to override the other. Unless you're like a really trained musician or something like that, so then you probably have the ability to do two different rhythms at the same time. All right. So we've talked a little bit about this, but I think it's one of the most important things that we need to cover is the diagnostic pitfalls. So how can this diagnosis go wrong? So I think one thing that happens a lot is people say, oh, this patient is FND, they can't have anything else. That is not true at all. So I've seen patients have FND and all sorts of weird zebras and unicorn diagnoses. So you can absolutely have a functional diagnosis and something else, including things like MS, epilepsy. I mean, the most common patient population that we see non-epileptic events in are patients with epilepsy. So 30% of people with epilepsy will have a non-epileptic event at some point in their lifetime. So the idea that these things can't coexist is nonsense. So I think that's really, really important to know. I think it's also important to know that bizarre does not equal FND. So I do see a lot of weird things in my clinic, and oftentimes the symptoms tend to be more bizarre than what you might call a traditional neurological disorder. But that doesn't mean that all bizarre things that therefore become FND. And a good example of that is a patient I saw in training, also on the adult side, but he had a very rare diagnosis called neuroacanthocytosis. Incredibly rare. It creates one of the most bizarre gaits you'll ever see in neurology. They call it the rubber man syndrome because they have such a hard time walking, and it's just a really severe form of choreoathetosis. And so you don't have to have just because you have bizarre features does not mean it is an FND diagnosis. So you don't want to miss something that could be underlying this or two different things coexisting at the same time. You also want to make sure that you base the diagnosis on the positive signs and symptoms that you're saying. So you're explaining to the family, I know this is the right diagnosis because I can see this weakness changes if you start using your cell phone or something like that. Or you have a non-epileptic event only when we're talking about the non-epileptic events, similar to how some patients have functional tics. And so you start talking, well, patients with tics also will sometimes talk. The more you talk about the tics, the more the tics come out. But there is also it's a whole separate topic, but there's, functional tics or TikTok tics is something I also see a lot in my clinic. And so the way that you can distract the brain away from its current symptoms tells you a lot about what the symptoms are. Whereas if you have Parkinson's or something else, you're not going to be able to distract away from those symptoms. And then you don't want to make assumptions based on a patient's psychological history. So I can't tell you the number of times I've seen depressed teenage girls come into my clinic and someone said, well, they must have FND because they're a depressed teenage girl. That's ridiculous. And so we see lots and lots of patients of all walks of life, high achieving people with intellectual disability. It does not matter what their comorbidities are. Anybody can get FND. I'm pretty convinced that, I should say, most people can get FND. And the psychological history is not that useful of a component. And so the number of patients I've seen with, because I distinctly remember this one patient, teenage girl, came in wearing a giant bow in her hair, like the largest bow I've ever seen. It was bigger than my head. And so she's got it in her hair, and she was a quirky kid, and she had an extensive psych history. And of course, and unfortunately it was a neurologist, said, this girl's odd and has this extensive psych history, so she has PNES. And then I looked at the video that the parents, and her events happened at night, to be clear. And so I look at the video, I'm like, well, that's clearly a seizure. That's a focal seizure that's happening. And so I'd explained to this family that unfortunately the neurologist got it wrong. And so one of the things that I enjoy about my clinic is I do often get to undiagnose somebody of PNES or FND. So I get to tell them, we don't always have it right. We make mistakes sometimes, and that's okay as long as we arrive at the correct diagnosis. Other diagnostic pitfalls is that you don't want to ignore FND, conversely. So we absolutely see patients that get this extensive workup, and usually it's because of family requests and stuff like that. So they don't want to accept the diagnosis, and so people leave FND off the differential entirely, or they kind of shy away from explaining it. We shouldn't be conceptualizing of FND of anything else other than as a standard neurological disorder. It's just like migraines, it's just like epilepsy, anything else. So the idea that we've abstracted it away and said, oh, it's this weird psychological thing, that's not really true. Hopefully I've convinced you of that there is a biological basis of this. I think there's probably also a biological basis for most psychological things too. And we can explain this to families that this does not preclude you from getting other diagnoses, that this isn't it shouldn't be stigmatized in any way. It shouldn't change how you're treated at school, because that's the other thing that we sometimes see happen is at school, families will relate to us that they've experienced discrimination and things of that nature. We shouldn't be discriminating against kids that have Tourette's or epilepsy or whatever. So I don't know why FND gets kind of singled out, but I've tried to, or one of the things our clinic tries to do is we try to dispel some of these myths and rumors about the incorrect information that exists about this diagnosis. The other thing that can be concerning is kind of going too far the other direction. So you get an MRI on a patient with FND and you see some nonspecific T2 white matter lesions. We see those a lot. I mean, it's probably 5% of patients. I don't know the exact percentage. Same, it's kind of like seeing Chiari. And that's another thing that we often see in our clinic. And families will say, well, that's the explanation for the symptoms. Like, no, that is an asymptomatic Chiari that 5% of the people have. It could not possibly explain these symptoms. So if you order a test, make sure you're prepared to explain that test, because sometimes it leaves families asking more questions, unfortunately. All right, and then the thing that I think is also important to recognize, if new symptoms pop up, especially if they're not explicitly neurological symptoms, so we often see things like vocal cord dysfunction, asthma symptoms, GI symptoms, stuff like that. We don't always assume those are, we shouldn't assume those are FND related. They could be, right? You can absolutely get functional chest pain, functional abdominal pain, but it's not something you want to dismiss out of hand and say, oh, it's just FND, don't worry about that. And so we often tell families that any new symptom requires an evaluation of what that symptom is, and then we determine if that needs further workup or not. So if you have chest pain and there's characteristics of the chest pain that sound concerning, we would get an EKG. If there are characteristics of that shortness of breath that sound very reassuring, like it's more panic-related or anxiety-related, we would treat that as that. So everything should be kind of evaluated on its own merits. I like to really avoid the stress and anxiety language of FND, because I think the thing that often happens, and this happened to me in residency, where you tell somebody this is a stress-related diagnosis. The first thing they're going to ask you is, what can we do to eliminate stress? Well, you're a teenager. I don't know what you can do to eliminate stress. So, and they'll ask, well, should we cut band? Should we cut, football, cheerleading, whatever it is? And so they'll start going down the list of all the things they have in their lives and asking you to make the determination as the neurologist or pediatrician, what can we cut out of their lives? That is not our job. And then I tell families that very clearly. I say, this is up to you to decide what is important to you as the child and what is important to you as the parents that you all want to work on, but you shouldn't be pulling out of activities, because that's only going to make the symptoms worse. So the way I explain the diagnosis, this is kind of the most important slide, I guess, and I think I like to put it in very detailed context. So I give families the clinical signs and symptoms I see on exam or on videos. I explain what those signs and symptoms are and how they could not be compatible with another neurological diagnosis. Some people use the hardware-software analogy. I've kind of shifted away from that, but I think it is a very easy to grasp concept, right? So the idea that software would be like our motor planning and stuff like that, and the hardware is the actual structure of the brain. And so you can explain that to the family and maybe get a little buy-in from that. I like to go to the next step and just tell them about the agency hypothesis. So I explain, this is what the modern neuroscience shows. There are studies that can do this. We can't do this here in our clinic. This is not something that I have the capability. We have an fMRI scanner, but I can't do the same protocols that were done at the NIH. And so, but I explain that this is being studied. This is something we've gained a lot of knowledge on in the last 10 to 20 years. We're going to keep gaining more knowledge about this. And what we know now is very reassuring that this is not a electrical process, so it's not seizures. We don't need to treat with anti-seizure medicine. This is not a structural process, so we don't need to get an MRI if we haven't already gotten an MRI. And so I tried to make it clear why more testing is not going to give us the answers we're looking for. Doesn't always work, of course. Some families still want more testing, and I will offer that testing. So when I first started doing this, I was very opposed to doing an MRI because I thought, what happens if something's abnormal? Is that just kind of feeding into this, pattern of behavior? And so, but then I realized that you can actually get a lot more buy-in by meeting families where they're at, getting the MRI, proving to them that the MRI is normal. And I'd rather be the one to order the MRI, because I had a patient one time that I kind of refused to order the MRI. And then a different doctor, I believe it was a physiatrist, ordered the MRI. It showed some white matter lesions, and they referred that patient for MS treatment. And it was clearly not MS. It was a benign white matter lesion that we see all the time. And so I tried to take a little more ownership of those patients, say, we'll order these tests if that's what you want, but I expect them to be normal. And so prepping them for that information is really, really important. The best part, the silver lining to all this, is that we have good prognosis information. We have 2 long-term studies that followed patients for about 10 years, and each study was about 100 to 200 patients. It's not, the highest level data in the world, but it is reassuring that these 2 longitudinal studies, and one of them was done in Europe in I think it was the Netherlands. They have great longitudinal data. They can follow people for much longer because they have detailed records of where they live and all the healthcare they're receiving. 80% recovery. So most teenagers, by the time they're adults, have resolution of their symptoms. And so I think that's the kind of key piece that I like to reinforce to families. And then I usually will have teach back. I want them to explain it to me as I've told it to them so that I get some understanding of what their understanding is. And then referring them to additional resources I think could also be useful, and I have some of those links at the end of this presentation. So critical aspects of treatment, we want to keep them in their normal activities. We want to keep them in school, most importantly. So homebound is like my biggest nemesis. So I have to fight homebound all the time. And that's true for my epilepsy patients. That's true for FND, whatever. Like, we know that keeping kids in school, the social aspect, the educational aspect, is by far and away the best thing for them. I want to keep them in activities, so we often have to work with like coaches and stuff like that to figure out how we can still keep them in sports or whatever their extracurriculars are without limitation. And then we often refer to things like physical therapy, psych. We coordinate with community resources so that we're not following these patients long-term. We'll see them for 1 or 2 visits, and then we kind of discharge them back to the community where they're getting a psychologist or a physical therapist or whatever to manage their ongoing symptoms. And then we're available as needed on a supportive basis. The most important thing, I think, is that if you're going to diagnose somebody with an FND diagnosis, you need to have some sense of follow-up. You need to figure out what's happening. Are they getting better? Because if they're not getting better, you need to reassess if you have the right diagnosis. Our clinic is very busy, as I alluded to. So in 4 years, we've seen 330 patients. We've had to decline referrals from lots of places so you might ask, why did we see somebody from Hawaii? There's nobody in Hawaii to see this diagnosis. And so somehow they were able to get to Texas. And so we said, okay, we'll see you for that reason, because there's nothing better for them out there. And this is true for lots of states, unfortunately. So we're not the only game in town, we are the only game in town. We're not the only game in Texas, but there are very few clinics like ours out there. Most of the really big academic centers will have a clinic like ours, but there are many, many places that don't. And so that's why we have to be selective with who we see from out of state, because I don't want to take a patient that can come from Ohio when they have clinics like this in Ohio. That would be a much better place for them to be seen. But for patients that are coming from Louisiana, there's no better option, unfortunately. And so we have some follow-up data. I apologize, that's a little bit outdated. So we have, I think, 67 patients that we have follow-up data for. 95% did not return to the ER. 83% had improvement, and 30-something% had complete remission. So really good evidence that even just a single visit or 2 visits can make a huge difference for these patients. So treatment, what does treatment actually look like? I'm not the psychologist. I have a psychologist that I work with in the clinic, so I'm going to do my best to summarize what she does, but it's not going to quite do it justice. So the most evidence is for CBT, which is cognitive behavioral therapy, but there's some evidence for other forms as well. And so we focus on CBT because that's what our psychologist was trained in. And she was trained in the one randomized controlled trial that's been done in children for psychogenic non-epileptic events. So there's a treatment called REACT, or, oh boy, retraining and control therapy. There it is. So REACT is now undergoing a larger NIH study, a multi-site study looking at its effectiveness in several different institutions. But we have evidence that it's 95% effective in children with PNES. And so that's where Dr. Elliott trained. She is able to do that sort of therapy, and that's what we kind of employ in our clinic. Interestingly, that's based in research that was done for kids with tics. So we use CBIT, Comprehensive Behavioral Intervention for Tics. And so that kind of came out of the same data, which also then came from a treatment for epilepsy. So in the I think it was in the late 80s, early 90s, there was a group at Stanford that used neurobehavioral intervention for focal aware seizures. So you can actually interrupt the aura of a focal aware seizure by doing a very similar treatment to what we're doing. So you're changing your thoughts and you're changing your body's movements to send new signals in the brain, and that can actually interrupt a early focal seizure, which is really incredible stuff. And so it's all kind of relates together because it all shows you how plastic our brains are and how we can change the way our brains think. So our goal of treatment is we want to improve events and we want to improve that self-agency. School can often be one of the biggest barriers to this. I say school and parents sometimes, I guess, because when parents intervene, it's a very natural parental response to see your child in distress and try to help, right? But the problem is if parents are splashing water on their kid, if they're helping their kid breathe through an episode, if they're doing anything external to that patient, they're not letting the patient get control over their body again. And so we're trying to encourage self-agency, which means they need to be doing that themselves. They need to be retraining their brain themselves without external factors. Also, you're not always going to have your parent or your teacher. And there's even some treatments out there that we don't subscribe to, but other places use, like having the patient have a sour candy or something like that. And that is a reasonable thought because it distracts the brain, it changes the brain's attention. But the downside to that is, what if you don't have sour candy with you? So the therapy that Dr. Elliott does is done in such a way that you could do it anywhere, anytime, minimally interruptive, and so they could do it in the classroom, and it's not going to pull them out of the classroom, and that's kind of the goal of what we're doing. And then we want to change the way that the brain thinks about these events, because oftentimes patients have a lot of fear surrounding them, like, what if I have one in the classroom? What if I have one in front of my friends? And so we try to change that, and that's kind of the cognitive behavioral piece of changing the thoughts, that the kind of automatic intrusive thoughts that people have about these events. And so we kind of focus on all those different issues, and then specifically we target school because we want to make sure school's not pulling them out, not sending them home. Schools, we work very closely with them because I understand their frustration on this, that when you have a patient that's some schools have to shut down the entire school for a non-epileptic event. And so there's a lot of liability from their standpoint that can be troubling. And so they feel that they don't know how to respond to these episodes. They don't know what to do. And that's where we've done lots of education with school districts. We also have an upcoming presentation at the National Association for School Nurses, which happens to be here in Austin. And so we're going to be trying to get as much education out there as possible. And then we know that withdrawal from school is one of the biggest quality of life factors too. So it's the same reason why in adults they lose their jobs, they can't drive. The state law is kind of ambiguous in terms of it just says if you lose consciousness, you should not be able to drive from at least 3 months from the last episode of loss of consciousness. It does not stipulate if that's syncope, seizure, or non-epileptic event. And so we have to educate our families on that, which then becomes a really good incentive. I mean, teenagers care about driving, right? So it's one of the best treatment motivators that we have to get kids in treatment and get them successfully treated. And most of our patients do drive, which is pretty cool. So returning to school, we can't just diagnose people in the hospital and send them out without a plan, because the school will freak out, they won't know what to do, and then they'll just keep coming back. So we have a school letter that we send with all of our patients. We modify it depending on their symptoms, and then we also give the patient a separate treatment plan. And so with those two pieces in place, most of our patients are able to stay in school. We still occasionally have there are some patients that pose unique challenges based on the school they're in. Unfortunately, there's a lot fewer school nurses than there used to be. So I remember growing up that like even elementary school, I feel like had a school nurse. Now it's like you might have a high school with 4,000 students and there's no teacher or no school nurse or something like that. So it's a very stressful situation for the schools as well. And so we try to be mindful of that and try to help them as best we can. So to summarize, this is common. It's real. There's a very strong theory for a biological basis of this. Yes, there is a female predominance. We don't fully understand that, but that does not mean that males do not also get it. Does not mean that every female has this. So just because you have a female with new neurological symptoms that seem a little bit weird, don't assume that it's FND, we have to prove that it's FND. And then these patients have some of the lowest quality of life measures in neurology, but we can do a lot to help with that. So we can treat the comorbidities that are involved. We can get them back into their activities that they enjoy doing. And we know that these symptoms can get better over time. I think neurologists and pediatricians have a huge role to play in this because we see this a lot. Obviously, y'all see it, and we're going to keep seeing it. So what I tell the residents all the time is, even if you don't like this stuff, you don't have to like it as much as I do, but you're going to see it. So you might as well be good at doing it, right? And then we have treatment available. So definitely refer to our clinic if you have patients with this. Some patients, not every patient needs to come to our clinic, in my opinion. We definitely have patients that they get a good explanation of the diagnosis, and then they get better. And so the conversation itself can be curative, which is a really cool thing. And so, but for those patients that do need that kind of higher level of care, we have this clinic for this reason. So we can do brain retraining therapy, we can treat those comorbidities and address the social factors involved. And then if you're interested in this stuff, there's a really cool organization. We actually need more pediatricians in this organization called the FND Society. And so it's a relatively young group. It started, I think, 6 years ago. Mark Howlett was one of the founding members of it. And they meet every 2 years for an annual meeting. It's international, so sometimes those meetings are in cool places like Verona or Prague. That's not a good reason to join it, but it's not a bad reason to join it also. A good reason to join it is that it's one of the cheapest organizations I've ever been a member of. So we're members of lots of things, American Academy of Neurology, American Academy of Pediatrics, but FND Society is very low cost, and you get a lot of learning material from it. So a lot of the stuff that I was talking about that we do in our clinic, they have a templated version of like a school letter. They have all sorts of stuff that could be really good resources for providers. Thank you very much. Any questions? Oh.
So actually, your colleagues have requested that I ask you this question because I asked it to a previous speaker, and it should really be a question addressed to a multidisciplinary group. So I'm sorry to put you in the forefront for this. But last week, we had drama club at the office. I mean, we had teenagers having all kinds of reactions. Of course, they don't know pediatrics. So if they're given Rocephin, which is an antibiotic, they'll have a reaction like you would have after albuterol nebulization and vice versa. And if I have to take like 5 seconds for that to go through my head, I want to make sure about what's going on. I'm asking for a 1 second thing, like how can I do this faster? Like tell if it's real or not real. And then I have 2 minor comments. I don't want to deviate away from the main question because this is important to me. Thank you.
Yeah, okay. So you want a very quick way to assess, is this an acute neurological emergency or not?
Yes, or an allergic reaction too. That's why I said it could be multidisciplinary as well.
Yeah. So the long-term treatment of FND, we try to minimize medical attention, so we don't recommend doing pulse ox and vitals and all that kind of stuff. In the acute setting, especially with new symptoms, like right after getting Rocephin or something like that, I would absolutely do all those things, do your kind of standard of care stuff, and because you want to make sure that the patient is not acutely decompensating. And so if the vitals are completely normal, yet they look like they're in a considerable amount of distress, and that distress doesn't match with the vitals, that's when I would be a little bit suspicious. And so we do see that where we have kind of things like somebody having I guess the part where it's tricky is that acute dystonic reaction could occur, and they could still have intact mental status from that, but still have a really bizarre motor presentation of that. And so what I generally tell people is that if you're not sure what it is, err on the side of treating the dangerous thing. Err on the side of treating it as a seizure, even if you think it could be a non-epileptic seizure, until we've proven that it's a non-epileptic seizure. Because if you give somebody a dose of Ativan and you think is having an epileptic seizure, you're not going to hurt them. Let's say you're wrong. So let's say it actually is a non-epileptic event. Giving that 1 dose of Ativan is not going to be a problem. We'll fix it on the back end when we figure out if it's non-epileptic, we can explain that. So in that situation where you're worried if this is an allergic reaction or an acute dystonic reaction, I would treat like that. And then if we figure out later, that's okay. And so I will say that we definitely see that happen too, where after getting a vaccine or something like that, people have psychosomatic responses to that, right? But we can always deal with that after the emergency is over, if that makes sense. Thank you. Yeah. Other questions?
So you mentioned that they're not allowed to drive. What about other seizure precautions like swimming or climbing a tree or whatever?
Great question. One of my most interesting patients, the family didn't really want to believe the diagnosis at first. They thought that this could still be epilepsy. And so I said, okay, let's treat as if it was. Let's have some swimming precautions in place. And so the patient, as it turns out, is a swimmer. And so I said, well, maybe when you're doing competitive swimming, swim on the outside lanes. Apparently, that's not where the fast swimmers go. And so I got in trouble for that. And so, yeah, it's one of those things that, so we do sometimes give those precautions, especially if we're in a gray area, we're not sure what to do. If it's truly non-epileptic, and there's no doubt about that, there's no risk of like comorbid epilepsy, I would say they don't really need swimming precautions. I would say just standard, having an adult supervised, just like any other kid that would be swimming, but not to the level that we do for epilepsy. And even in epilepsy, we have kids that swim, so we give, relative precautions, but we don't restrict them from doing things. So if I had a patient with epilepsy, I'd say maybe don't go swimming in a lake, big lake without the ability to be rescued but if they're swimming in a pool and they have an adult supervision, that's fine. Yeah.
Can you tell us how long do they need the CBD therapy on average?
That's a good question. So it varies depending on the patient. The standard REACT protocol that's being tested now in a larger NIH study is, I believe, 8 sessions. So it's similar to kind of our headache program. And there's actually a lot of overlap between chronic pain and FND in the way that we approach it from a psychology standpoint. And so we have a headache program that's a multidisciplinary headache program. And it's the same idea that they do like 8 sessions, kind of teaching coping skills to deal with chronic pain, and very much the same way that we do with the FND piece. All right. Thank you.